All right, hello and welcome to Avinger's virtual series of webinars. Thank you for taking the time to join us today. Today, we will be discussing traversing and treating chronic total occlusions, or CTOs, utilizing OCT-guided technology. We are joined today by a panel of leading interventionalists with extensive experience treating peripheral artery disease and specifically addressing the significant clinical challenge associated with CTO interventions. Please note that this webinar will be recorded. Participants will not be able to unmute during the session. However, you may pose questions to our panel by clicking on the Q&A button and typing in your question. Questions will be answered during the Q&A session at the end of the webinar. I will now turn over the call to Dr. Glen Schwartzberg, a vascular surgeon at Miami Valley Hospital in Dayton, Ohio, and former chief of vascular surgery at Baton Rouge General. Dr. Schwartzberg has been in private practice for 38 years and has extensive experience with OCT-guided technologies in treating above the knee, below the knee, within in-stent restenosis, and crossing and treating chronic total occlusions. Dr. Schwartzberg, the floor is yours.
Thank you, Alex. What I'd like to suggest to the audience is that this really is should be an interactive presentation, so that if there are questions that come up, please submit those, because that's the way that we all learn and we get better at what we do. So please take the time to do that so that we all get the most out of this. Joining me on the panel today are two very accomplished clinicians. Dr. Michael Lieb is a vascular surgeon, is the vice chair of the Department of Surgery at Virtua Memorial Hospital, and medical director of the non-invasive vascular lab, and medical director of the vein center at Virtua. He provides and engages in a full spectrum of treatment of patients with vascular disease and enjoys treating the challenges of carotid disease specifically, and also image-guided treatment of chronic total occlusions, as well as being involved in patients who are limb salvage patients and have extensive and complex arterial occlusive disease in the lower extremity. He also is involved in biomedical engineering and consulting with biomedical companies. Dr. Sharat Koul is an interventional cardiologist and vascular interventionalist at St. Joseph Hospital in Lexington, Kentucky. He has over 23 years of clinical experience in the treatment of both peripheral arterial disease and coronary occlusive disease. He's worked for over 15 years as the director of the limb preservation program in Kentucky, and specializes in complex arterial interventions in patients with non-healing wounds and CLI. It is published in multiple journals and manuscripts, and is also on the advisory board and management boards of the hospital system in which he participates. So the program is going to consist of three components. Dr. Lieb is going to present challenges of crossing and treating chronic total occlusions, and the considerations that go through his mind with regard to him being an interventionalist using image-guided technologies to cross these lesions. And Dr. Koul is going to present an overview of OCT-guided technologies and the clinical data associated with the benefits of OCT-guided technologies. And then I'm going to present a case that's illustrative of the benefits of both OCT-guided crossing and OCT-guided treatment of complex arterial occlusive disease of the lower extremity. So Mike, if you would please take us forward.
Thank you, Glenn, and thank you for having me. It's an honor to be here presenting tonight with Dr. Schwartzberg and Dr. Koul. All right. And so tonight we're talking about the challenges of crossing CTO lesions. And so chronic total occlusions, we all incur these in our everyday practice. By definition, it's greater than a 99% stenosis of an artery for greater than 3 months. So this separates out the acute occlusive disease and also the severely stenotic disease. Looking at CTOs in general, they make up roughly 40% of the peripheral vascular lesions we all deal with, but when specifically looking at the superficial femoral artery, they can make up a little over 50% of those lesions. Looking at this cross section of the artery here, we can see the outer pink layer, that is the adventitial layer of the vessel, the outer wall of the vessel. And then you have the media, which is the lighter pink layer here with these little triangles in it. Within that is calcium deposits within the vessel. And then this is the intimal layer here, which is this light pink layer. It's got an internal elastic lamina. And then this is the filling defect within the vessel, which can be various things. It could be either be calcified plaque, soft plaque, thrombus burden. But these are the complex nature of these lesions. It's often a mixed type lesion. And so there's certain challenges with treating these CTO lesions. And some of the issues with dealing with a CTO lesion rather than just a stenotic lesion, there's lower procedural success rates. You have to actually cross the lesion and preferably within the true lumen. And if you can't cross the lesion at all, no procedure can be performed there. These lesions tend to have a higher recurrence rate and require repeat interventions. And that has to do both with the nature of the occlusion itself, whether it's a heavily calcified plaque versus a softer plaque. It has to do with the length of the lesion and how much plaque burden you're dealing with. Unfortunately, these have a higher amputation rate and bypass rates, and that again goes to the fact that there's higher complications in treating these lesions. These lesions in general to represent lengthier procedures. It can often take a significant time to cross these lesions in a true plane, and if you're in a false lumen, you have to re-engage the true lumen. And unfortunately, this also leads to higher costs as more and more products are used to both cross the lesion and ultimately treat these lesions. And just on the side here, we're showing two different CTO lesions. The first lesion on the right side is showing almost a flush occlusion of the SFA. The profunda is widely patent here. You can see a little nub of an SFA, and then the rest of the SFA is obliterated here. And then this is further down, there's reconstitution, basically just above Hunter's Canal, where it crosses over the femur. And so this whole lesion would need to be addressed. As far as the limitations, so in general, when crossing these lesions and angioplasty is performed, we often overlook a little bit of the damage that happens to the vessel. Oops, sorry. The damage that can happen to the vessel, that's not often picked up on the angiography, but there's several forces that happen when you're performing balloon angioplasty. There's the radial outward force of the balloon, which I think is the one everyone thinks of the most, but there's also longitudinal forces and orthogonal forces that happen in the balloon stretching and tearing the intimal layer of the wall. If these tears go deeper, they get into the media and ultimately can dissect through all layers of the wall. And then as far as conventional treatment options, there's a higher failure rate with CTO lesions because often the wire and catheter, or the wire, gets directed in a subintimal plane. And then you have to get back into the true lumen of the vessel. And sorry, the damage to the vessel can also, depending on how damaged the vessel is, you get this healing response. And so you get pro-inflammatory mediators that get released to then repair the arterial wall. But in repairing the arterial wall, this is leading to a restenosis, which can happen in up to 75% of these lesions in the 12-month period that follows treatment. And so again, just going over the arterial wall, if we look at the top picture, this is a very clear picture of the vessel wall where we see the adventitia on the outer purple layer. There's an external elastic lamina, and then the media, and then this fine black layer here is the intimal layer. If after treating the vessel, these layers are damaged, this is what leads to the repair response within the vessel, which ultimately leads to restenosis. And so when you lose these clear planes between the adventitia and the external elastic lamina, the inflammatory mediators are released. And so we know that when performing atherectomy, if there's any adventitial disruption, it happens in roughly 50% of the patients. But if there is adventitial disruption, we know that the restenosis rate is significantly higher in 1 year following that treatment. Again, 97% restenosis rate if there is adventitial disruption versus 11% if there's no adventitial disruption. And so, again, if performing balloon angioplasty leads to disruption of the intimal layer, that's going to lead to an enhanced healing response on the vessel and more stenosis. This was a study that was looking at the levels of disruption and how much disruption the vessel can handle. And so they labeled this as grades A through F, actually. Disruption, grade A was just a slight lucency on the vessel, but no clear disruption of the vessel layers. Grades B was a linear disruption in the vessel, but still filling through the vessels. Grades C, D, and E were various grades that was ultimately a spiral disruption of the vessel, a complete occlusion of the vessel in the end. And basically, this showed that the more disruption you had of the vessel, the worse the dissection, the worse the both short-term and long-term outcomes were for the vessel. And so the XLPAD study, this was looking at different ways of crossing these CTO lesions, the standard wire and catheter directed versus using a crossing device. And there were several different crossing devices used. But what they showed was that while there was similar technical and procedural success rates between the two, it did favor higher both technical and procedural success rates if you were using crossing devices. However, if you look at the outcomes following that, if a crossing device was used and stayed within the true lumen, you had lower rates of revascularization and lower rates of needing surgical intervention. The amputation rate and ultimately the death rate were significantly less in those patients. And then this final study, this was looking at crossing CTOs as far as they broke it out into long segment and short segment lesion lengths. And what this showed was that the longer segment stentings resulted in significantly decreased patency rates. And so in using these crossing devices, especially the Avinger system, the Ocelot system, and ultimately the Pantheris system, you get intraluminal visualization while you're doing the procedure. And so you can see certain areas of the vessel that need to be treated and certain areas that actually look okay and don't need to be treated. And this allows you to place stents only in the segments that have significant disruption and not stenting the segments that look okay and don't have any significant disease. And this was looking at using a crossing device. This was actually a barred crosser device, but these patients actually had a subintimal crossing of a lesion and then had an IVUS and a pullback performed. And what they found is that if the ultimately, if the lesion was crossed greater than 90% within the true lumen of the vessel, there was a significantly lower need for revascularization at the 6-month period. And their cutoff was basically at that 90% mark, which if you crossed more than 90% of the lesion in the true lumen of the vessel, the need for revascularization was significantly less at the 6-month period. And so these are a few selected images from that study, and this was going over, these are IVUS images, but this was going over some of the reasons why the results were poorer if you had significant subintimal treatment of the vessel. You can see in the first picture all the way to the left, these are collateral vessels, and these are collateral branches that come off. If you get into a subintimal plane and then subsequently treat the lesion, you lose these collateral branches as they get compressed by the stents. Also, in crossing in that subintimal plane, in this central image, you can see that there's then the possibility for a periadventitial hematoma or blood to fill that area. which then takes up space. It can compress whatever further treatment that you have planned. And then finally, the last picture on the right is showing kind of the worst complication that can happen is you get a perforation of the vessel or blood outside the vessel lumen. Now, if you look at these images, and again, these are IVUS images, you lose some clarity of the vessel wall. You can see where the edge of the vessel is, but you don't get to see the actual layers of the vessel when you're treating it. And so this is where, and you'll see on the next presentation where we have our OCT images, you get much better clarity of the vessel lumen, and you can see exactly where you need to treat up to without getting too close to the external elastic lamina and ultimately the adventitia. And so there's very clear planes that we're going to be able to stay within so we can adequately treat the vessel, but not get too aggressive and cause complications. And so ultimately, what are we looking for with these crossing devices? Is we're looking for, obviously we want to stay as minimally invasive as possible and offer the patient the least invasive option, which is also going to be the most successful. We're looking for something that crosses within the true lumen of the vessel. As we'll talk about in the next presentation, we can limit the amount of radiation and ultimately contrast that's necessary for these procedures because we're using the OCT imaging for portions of the procedure rather than fluoroscopy. We have the ability to minimize any dissections. You can very clearly see when you get into the dissection plane with using this technology. If you do, you can pull back and re-guide into another plane. And you can also see where the damage is to the vessel, if there is any, or where the major plaque is to the vessel and treat just those areas rather than blindly treating a vessel throughout. And again, lastly, you can use your adjunctive therapy only where it's absolutely necessary, and that will allow for shorter stents and less stenting that needs to be done, which will ultimately lead to better results for these patients.
Thank you, Michael. Very, very good presentation and a lot of good information. I appreciate that. And Sharat.
Yes, I think we'll thank you very much for having me. It's a real honor to be able to present all this wonderful data with my very esteemed colleagues who have a tremendous amount of experience in this field. I'm going to be talking about OCT guided intervention, some of the technology overview, and some of the data. I'm the resident interventional cardiologist of the group, so I'll be presenting some of this data, which is always seems to be our purview. So what is this all about? It's all about OCT imaging. And OCT, optical coherence tomography, it's been around for a very long time. It's basically just a light. It's a machine that shoots a little bit of a light out towards the vessel wall. The reflection back is interpreted by the machine to look at depth and density to reconstruct a picture. And on the left, you can actually see a very elegant representation of how you can see the details of the vessel walls. And I would just the way Mike described the IVUS imaging as sometimes being blurry. You know, I cut my teeth on IVUS in the coronaries, and despite your best efforts, sometimes you just can't tell what's going on. The OCT produces a much clearer image, and it's very nice to be able to be more precise in terms of your treatments. You know, on the right-hand side, we see fluoro guidance. This is our traditional back in the day type way of dealing with things in terms of atherectomy and such. We used to have CTOs. We used to go off fluoroscopy. And if, you know, again, I know that my colleagues are also probably back in the day when we used to use the old atherectomy systems, and you just kind of might dig a hole in the wall, vessel of the wall accidentally, because it's hard to tell exactly where you need to begin and where you need to end. But this is the kind of thing that you can avoid with OCT guidance because you have very clear visualization of the plaque. You can see here the plaque kind of hugging up against this catheter. You can see this is the open side of the catheter. This is the cutting side that's facing the plaque. You can clearly see the media, and you want to, of course, avoid that adventitial injury, which we know is basically a powerful trigger for an injury response and restenosis and such. So we'll move on. Okay, some of the technology that we're looking at. Now, this is a depiction of a device. This is the small vessel device that's used predominantly in the tibials. But again, it shows the OCT delineation of the layers that you look at. You see this with the crossing systems as well as you see this with the cutting systems. And here again, you clearly can see the external elastic lamina right next to the media. You will see that large plaque burden that you kind of want to focus your cutting on, and as you move the catheter system, the cutting system through the plaque, you can see how the blade moves through the plaque, and you can actually very precisely stop where you're getting close to that median EL so that you can avoid that injury. Again, like it says, precision guided, enhanced control. One of the big things I have always been, the reason why I'm a huge proponent of this system is safety. I think that the safety issue is paramount in terms of safety to the patients. You minimize misadventures, safety to the operator, safety to your staff. I'm a big guy for reduction of radiation exposure to staff, to the physicians. We have long careers. We're doing this for 30, 40 years, and that fluoro does stack up on you. And if you can do things to reduce that while enhancing safety, that's a huge thing. We'll move to the next slide. This is a depiction of the cutter, the Panthera system. So you can see that spinning light kind of a structure. That's the actual OCT imaging element, and that actually sits right next to where the cutter, of course, exists. The cutter that, if you guys are, I mean, we're all probably used to some of the older other systems that are out there, but basically this utilizes there are two forms by which you can oppose the blade to the actual plaque. This uses an apposition balloon that you can see here actually at the bottom of the structure. It looks like just a circular bulb. You can actually inflate that balloon and actually control how much apposition you have with the device. And then by advancing it forward, you of course can cut, and while simultaneously real-time watching the OCT imaging to let you know that you're not getting too close to the adventitia to avoid that injury that we're looking so desperately to avoid. Let's see if this will, okay. This is the Panthera's large vessel system. It's a 7 French system. It's generally used in the SFA. You can see the range that it cuts in, 3 to 7 millimeters type vessels. It has a nose cone, which is between 6 and there's a 9 millimeter centimeter nose cone. You can see the large segment, which is the nose cone, which actually will store, of course, the plaque that you excise from the vessel itself. In terms of what we see on the right-hand side, you can see what's delineated as the cutter's edge. You can see the layers, of course, in terms of furthest out there, you see the EEL, then you see the media, then you see the plaque, and then that weird-looking structure behind the cutting edge is your balloon, and you can usually see that very clearly because it has kind of that shimmery look to it, and that's the one that you will inflate in order to provide apposition and control the depth of your cut. It's a very elegant system. It's a very very user-friendly system, and it's very efficacious.
Sharat, I don't mean to get you off track here, but let me
Sure.
ask you a question if you don't mind.
Sure.
So the image that's portrayed there is just a static image, right?
Yeah.
So you can point out the media, the EEL, etc. When you're looking at a real time, when it's moving, when things are moving, and you get some little bit of blood in there that can obscure your vision,
Mhm.
how long did it take you to feel comfortable being able to identify the images, know where you are, and feel comfortable that you're in a safe place to cut and that you're not going to injure the vessel? And the reason I bring this up is many times when I have individuals that are trying to, become facile with this and are new to the technology, it's, well, what am I looking at? How do I know where I am? There's a lot of concern because, as you brought up, it's a safety issue. So they want to be safe with treating their patients. And they're concerned about the time it's going to take to become familiar with this and be able to engage in it in a one-on-one situation. So
for me, you know what, my original adoption of this technology was very focused on the OCT guided crossing systems. That was actually how I entered this whole field, and because I was very focused on, I tend to do a lot of wound Rutherford, 5s and 6s. That's actually like my whole practice, much to the chagrin of my my cath lab staff, because these are long, these are long complex cases. So multi-level occlusive disease was kind of where I lived. And so I got very used to OCT imaging, especially using the pixel systems and the Ocelot systems. And so for me, it wasn't a huge jump when it came to the actual cutter per se. I mean, I would say within 5 to 10 cases, you felt pretty good about where you were. And I think it just came down to, like I said, I may be cheated because I did, I don't know, hundreds of OCT guided crossing cases before we even started into the cutting. And so but I think that overall the imaging, especially on the new system, the newer system, the imaging is so excellent. I don't think that people should feel overly concerned in terms of, with good representation and spending more time in courses like this. Being able to, I wish we did have some videos. That would be actually a very good, a nice thing to show. People, operators, I think, should feel comfortable that they will get familiar with the structures that they'll see, and they'll see stuff that they'll be like blown away by, like, wow, I didn't even know that was. We just went by a giant clump of calcium, and we just went by some fibrotic tissue, and I think that people operators will get used to it relatively quickly. I don't know what your experiences were.
10 cases, 15 cases? I mean,
I would say 10, 15 cases is more than enough.
Okay.
I don't know what your guys' experience was. I know you guys are also very experienced users, so it's kind of hard to think back and how long it took, but what were your guys' experience, Mike and Glenn?
Mike, what would you say?
Yeah, I would say in the 5 to 10 case for most people to be comfortable. I felt a little more comfortable early on. I'm used to all the ultrasound imaging. And then using IVUS. So for me, it wasn't a huge jump to jump to this kind of technology. There was a slide deck that Avinger provided, and like you were just able to keep going over images, and you saw what you needed to see. I think as you get more experience, you just get more aggressive with the cutting. The first couple of cases, we created a lumen, but we weren't getting super aggressive and getting as close to that media as you can, versus now when you realize exactly how the few different systems work and how aggressive you can be fairly aggressive with these lesions. I think that's the biggest change. As you get further into the cases, you get a lot more comfortable with that.
And so when you bring that point up, I will tell you what has been sort of eye-opening to me about it is that based on the imaging from the angiography, I've found that there's very little truisms regarding that when you can look at it with OCT, because based on two-dimensional angiography, usually with OCT, I see much more disease there than what is represented on the angio. And so sometimes I have to pull myself back saying, well, if it's only a 20 to 30% stenosis, it doesn't need to be treated. But if it's a 50 to 60% stenosis that you don't see on angio, then those are the ones that I would treat. And so I think it's beneficial to be able to have that imaging to be able to then dictate the best treatment for the patient.
Absolutely. And I think that's actually another thing that is very true is that, and we kind of learned this from coronaries, and it's starting to come back to some extent, but you do have to, I think you do have to produce a balance between what you see on OCT and what you see on angiography. Because sometimes I think that for some users, it may, you may end up, chasing your tail in terms of trying to go after too much disease, but at the same time, I think the biggest thing is it allows you to be very precise in terms of your cuts. So try to work with both sets of data to really kind of optimize outcomes as well as optimize what you do for the patient. Does that make sense?
Yeah, absolutely, absolutely. Okay, I didn't mean to digress.
No worries, no worries. This is all good stuff. So this is the small vessel cutter. This is a 6 French system, 2 to 4 millimeter vessels in general. This does not rely on a balloon for apposition. It uses the traditional kind of a jog system, and I think you can see the jog behind. It has a similar nose cone, a smaller nose cone. I think I use this again because of the type of patients I take care of. I use this probably more than anything else because of all the wound patients. But I think this is also it produces a similar type of approach. And you can be, shaving tibials is it's not for the faint of heart at times. I mean, you cut a hole in an anterior tibia, you're looking at compartment syndrome. So being aggressive with a lot of traditional cutters may be tough in the tibial areas, but with this system, you should feel a lot safer about it because you can see exactly what you want to see. So I think this is if you're a big atherectomy guy in the tibials for CLI type patients, this is something that definitely should be looked at as a part of your armamentarium. Again, precision. This is what it's all about. The precision. You can kind of see here clearly the balloon in terms of what you see then on top of where you see the membrane, you see the advent tissue, you see media and plaque. There's not a whole heck of a lot of plaque here. There's a little bit, but again, this will give you the opportunity to shave as you're moving the device up and down the vessel, and it's a little bit of a practice thing where you push with one hand and you're also inflating, and you can actually produce a cut that's smooth and seamless that actually respects the length as well as the depth of the actual lesion. And it's pretty cool to do it actually very well, because you're like, it's not just like rote cutting. You're actually producing a very slick and smooth type of a cut. So that's one of the things that I think is afforded to you by being able to use the Panthera system very nicely. So these are these are some of the crossing systems. Ocelot has been around for some time, and this is the item that I cut my teeth in. I'm a big Pixel guy, just because I'm just a big. Pixel is the smaller version of the Ocelot. It's a 5 French system. The Ocelot is the bigger system. It has more body to it. You can see it has a tip, which is kind of like a drill bit. The Tiger Eye is their newer system. It is deflectable. It works within the body of a crossing catheter. The catheter itself spins at the same rates that are seen with Ocelot and Pixel. The older, or I say not the older systems, the first generation systems, I should say, but it has a little bit of a more aggressive tip. I will be perfectly frank, I'm still not used to the Tiger Eye. I'm still trying to get more used to it. I would like to try to use it more for a lot of these much more aggressive PAD patients with a lot of fibrosis and calcium. The Maverick is a Ocelot, kind of not a hybrid, but a takeoff of the Ocelot system. And the Maverick is actually designed to be more aggressive and deal with calcium a little bit more effectively. And I'm a big fan of the Maverick system as well. So here we're looking at some of the things that can be done. We see this is all below the knee disease. We see an occluded anterior tibial, or at least a fairly close to occluded, and the posterior tibial has subtotal occlusive disease. And here we can see the device. This is the small vessel device. It's a 6 French system, and it's brought down, and you can produce very controlled shaves. Very controlled atherectomy of these 2 vessels, and it looks like, and you can see you have a beautiful result, and you can do it, like I said, very safely, because you can actually see what you're cutting. And again, in these vessels, it can be sometimes a little bit tenuous to put atherectomy systems down, but with visualization, you get a very good result. Some of the data, cardiologists love data, and so we're going to show you some data. Probably the 3 biggest trials would be Vision, Insight, and Connect. The image trial is, I don't think it's completed yet, but Vision, of course, looked at to dictate kind of the safety and the ability to treat occlusive disease in the SFA using OCT guided atherectomy. Excellent luminal gain, excellent TLR in terms of reducing the overall TLR rates at 6 months. You can see the results, and I'll show you a little bit more in-depth data. In terms of below the knee, these are patients that you're looking at for atherectomy specifically, and the data is excellent in terms of safety and in terms of being able to produce a good result in terms of patency and being able to reduce the risk of restenosis. The Insight data is actually excellent, because the amount of stents that are placed in the U.S. I mean, I think it's dropped down significantly. But before, I mean, again, I cut my teeth back in the day when everybody was getting stented, and so in-stent restenosis is a real issue. They talk about like 250,000 in the U.S., I think, or maybe globally. in-stent restenotic lesions are treated per year. This data was excellent. It compared the laser atherectomy system, which has been a system that has been present for some time for treatment of this lesion, with Pantheris. And actually, they stopped this study early because the efficacy was so evident, and the superiority in terms of utilizing the Pantheris system compared to laser was very much evident. And so, and if I think at this point now the traditional like Hawk One Turbo Hawk system is contraindicated in ISR. I have used it in ISR back in the day, and seeing one get stuck is never fun. So just being able to visualize the plaque within a stent is actually a huge deal. The CTO crossing connect was basically to show the ability to do true lumen cross. This is again actually why I am a huge proponent of OCT guided systems, because it's kind of like what some of the data that Mike showed was that you can do anything you want to a completely occluded vessel. You can balloon it, you can stent it, you can shave it, you can do whatever you want to. But if you are able to achieve true lumen cross for these complex CTOs, the patency, the ability to get a durable result increases exponentially. And so that's why I'm being able to do this real time. I used to try and do these things under IVUS, ultrasound guidance. We have a tech and all this stuff, and you're imaging the vessel. It just was never the same. The ability to cross systems with, under ultrasound with wires and this and a tech, it just is cumbersome. And I mean, in my hands, at least, I should say, I was not as facile with it. These systems have been tremendous for this reason. So this is a vision trial to look at safety of the ability to use the IVUS, the OCT guided cutting systems. You can see that this is non-CTO data. The ability to get a good result with just Pantheris alone was very good, and then the adjunctive therapy increased it just a little bit more. The one thing I would talk about is stent rates. This is non-CTO data, but 5% stenting is pretty good. It's pretty good. That's what we try to do. I think that most modern practitioners, our ethos is to reduce stenting and try to avoid stenting as much as possible. And I think that the ability to do that with this is very important. And let's see, I'm talking too much probably. This shows the CTO data, which actually mimics that same thing that we saw. Again, you get good true lumen results. You will be able to do whatever you want to the vessel and have very good durability. I think this actually the bulk of these patients that were done with the CTO cohort were actually crossed with OCT guided systems, so the Ocelot or the Pixel and such. So I think that definitely adds together the idea that being able to cross with this OCT system plus utilize a cutter, OCT guided cutter, produces that much durable result. So just in summary, I think I talked too much. You are able to get excellent luminal gains with reducing risk of injury. You can treat CTOs much more safely. By providing atherectomy, you can be able to preserve options, whether it be bypass in the future, reduce bailout stenting, which is, again, what we really want to do when we treat these patients, because recurrence is always an issue. So I think that that's actually the biggest pluses for this technology. Yeah. Thank you very much for listening.
Thank you, Sharat. All right, I guess I'm up.
Hit it.
Alex, can you help me with this? Thank you. This is a case study, a patient of mine that presented with critical limb ischemia and rest pain involving her foot. By duplex scanning, it was found that she had a CTO of the SFA and single vessel runoff via her perineal artery. And she was not a candidate for a bypass for two reasons. One is she had an EF of about 30%, and she was a significant cardiac risk, and she had no vein. And my experience with cadaveric vein bypasses is abysmal, and I will do everything I can to avoid that. Next slide, please. So this is her angiogram, and I'm sorry that I don't have pictures of her runoff. For whatever reason, they didn't get copied, but she had single vessel runoff via her perineal artery. And so given this angio and given the fact that she's not a surgical candidate and that she is a significant surgical risk, I'd like to open up to both Sharat and Mike and say, what is it that would change your or affect your judgment as far as how you're going to approach this, or what are you gonna take into consideration when looking at an angiogram like this? Sharat, can you jump in?
So I look at this and the runoff is terrible. You can see that perineal very distal. I think at this point, you're talking about somebody who's going to lose their leg most probably if we don't do some kind of an intervention. This is kind of what I do all the time, it seems. But I think that the way I would approach it is be prepared to. I'm never in love with doing perineal sticks, but I would approach it very much the same way it looks like you did, above and below. I would use. I'm not a huge fan of pixel per se in the tibials because sometimes it can get a little bit awry. I think that I would consider possibly even going retrograde. I actually find it that I have some degree of increased success retrograde cross for perineals, but with a pixel system from below. Use a 4-5 sheath and go from below, and then see if we can get in touch balloons, touch wires. Use a Pioneer. Do those kinds of things in terms of trying to get re-entry and then go from there. Does that
Okay. Mike, what about your thoughts?
Yeah, I mean, I would approach this the same way. I mean, again, in these lesions, if you get into the subintimal plane here, trying to get back into any kind of true lumen is going to be extremely difficult. And so
Right.
I think very important to stay true lumen right from the very beginning. I don't know if you used it here, but after you were able to cross the lesion, did you put a filter down at all before?
Yes.
Okay.
Yes, I always use a filter. I always, every case I use a spider wire, unless I have to treat into the distal tarsal artery or dorsal pedal, because there's no place to have the filter reside without interfering with passage of the nose cone. But other than that, I use a filter every time because I've had to. One time I had to chase embolic debris, and that was enough for me. I wasn't going to do that ever again.
Right.
Yeah, I agree. I use a filter every time when I can reasonably get it in. So there's been very few cases where we haven't.
So let me ask you guys this. So many times you have conversations with your colleagues, and it's I can cross anything with a wire and catheter. And so I would when I look at this, if you try to cross this with a wire and catheter, 9 times out of 10, the wire is going to go down that little geniculate branch. It's not going to go. It's not. I don't think it's going to engage the nose cone, or the nose of the proximal cap. Would you guys agree with that, or do you?
I would agree with that. That's a big old branch. It would want to go down there a lot. I don't think it's unreasonable to poke it a little bit to see what you get. Use a like a PT2. I use like slick lubricious type stuff just to see if it would find something. Again, I would like. If I see what the perineal looks like, it looks like it's not unreasonable size, right?
Well, that's the popliteal. That's what I'm saying. They didn't. I didn't have the pictures of all the runoff, but so I will tell you that that's the SFA. It occludes. The popliteal shows up, then the popliteal occludes again, and I'm sorry the films aren't there. And then there was at the tibial perineal trunk, it reconstituted, and the perineal was a single vessel runoff.
Right.
So it's not a great representation.
Right there. Yeah.
About that.
Yeah.
So what I do,
I'm sorry. Go ahead, Glenn. Sorry.
Go ahead.
No, I was going to say. So were you thinking you just go straight in with a? Were you going to use a like an ocelot, or are you going to use a pixel? What were you going to use?
Yeah, I use the ocelot. For me, one of the trade-offs with the pixel is I'll use it potentially, or now I use the tiger eye to go in the tibial vessels, but the support in the catheter
Yeah.
is so significantly less than with the ocelot, that the pushability, that I really prefer the ocelot. So that's what I did. I used the ocelot. And Alex, can you go to the next slide, please? So yeah, these are the OCT images that I was looking at. So for those that are not familiar with the technology, those three rays are important. The middle ray is 180 degrees opposite from the working portion of the catheter. So that's the orientation that one uses in order to how in the mechanism of how to direct the catheter. So you want to put the middle ray on the quote unquote normal tissue or the recognized structures. And that's how you know that you're proceeding into the diseased vessel or the plaque that's there. And can you play the video, Alex, please?
These are just images.
Oh, okay. Okay. Well, the next one has, okay. Can you go to the next slide then, please? All right. So this one has video? Yeah. All right. So this is real time. This is what you're looking at. So the sweep on the ocelot is that it rotates 10 degrees clockwise, 10 degrees counterclockwise. So there's this constant dynamic movement of it. And as you progress, as one progresses down the vessel, going through the area of disease, there has to be a constant manipulation of the little control device to keep that middle marker onto the area of recognized tissue. And so the other thing that the OCT imaging provides the practitioner is information about the morphology of the plaque, whether it's fibrotic, whether it's calcified. And, you know, the premise that you can determine the amount of calcification based on an angio is really a fallacy, because you don't know if that calcification is luminal or in the wall. So this way you can actually see the lumen of the vessel to be able to determine if you have to use adjuvant treatments, what those adjuvant treatments may be. Okay, you can go to the next slide, please. And so as you can see here on the left-hand slide, I've gotten a little bit off the path because as the marker shows, that little crescent-shaped area is the lumen. So I'm subintimal at this point. This is near the distal cap where it became very, very calcified. So, yep, if you can play it, please. So you can, up in about 11 o'clock, you can see that area of the lumen. And then if you could turn around to about 1 o'clock, 2 o'clock, like an analog clock, there's calcium in the wall of the vessel. And so what happens is sometimes the calcium will deflect the working tip of the catheter off your path and deflect into the subintimal space, just like it does with wire and catheter. Okay, next slide, please. So this is what you don't want to see, and that's the adventitia. But at least when that's recognized, then the next maneuver is to make sure that you steer away from the adventitia. And so that's why the middle marker is on the adventitia, to try to steer back into a safe portion of the vessel to try to finish the crossing. Again, this is near the distal cap. Okay, if you can play, please. But unfortunately, I could not do that as I kept trying, because once you enter the subintimal plane, it's very difficult to get out of the subintimal plane. And so what I ended up having to do was use Pioneer at the distal cap to re-enter the true lumen. Next slide, please. And so again, you can, on the left-hand side, there's adventitia. The lumen can be seen at about 11 o'clock position. And can you play it, please? And so it sometimes, if one can identify the lumen, you can aim towards the lumen to try to use the ocelot or the tiger eye as a re-entry catheter. unfortunately, I could not do that. And that's the reason that I used the Pioneer to re-enter. Next slide, please. So after crossing and getting intraluminal with the Pioneer, the angio on the left shows the lumen that was created with the ocelot. So the ocelot will create about a 2 millimeter lumen in the vessel as one goes through that. And it will give me information with regard to the morphology of the plaque, so that it can then help me as far as my further treatment options. The other part of it is that if I know that I'm intraluminal, I'm sorry, that I was subadventitial, I know there's going to be a subadventitial plane and a portion of this lesion that I'm going to have to treat. And the nice thing about image-guided treatment options is that does not limit my ability to atherectomize if I want to, because one of the benefits of using the atherectomy catheter is that I can cut out that subintimal leaf to be able to have a luminal channel throughout. And then if I want to spot stent at the distal re-entry point, which I did, then it limits the amount of stent length that needs to be used. Okay. So this is the atherectomy. I used the 7 French device to debulk as much as I could, and also to cut out the dissection leaf. And then I ended up spot stenting or stenting at the distal portion where I knew that I had to re-enter. Okay. Next. And so these are the images, both pre and post with adjunctive treatment of the vessel wall. And I did use a DCB in that as far as treatment. Okay, next. So again, the technology is such that it is a little bit of a challenge to interpret the images and become very comfortable with that. No different than it was a comfort level of trying to go from a flip phone to an iPhone, right? I mean, it's totally different technology. Once you become familiar with one thing, changing makes you feel a little bit uncomfortable, maybe. I'm not trying to minimize what we do because in comparing it to a phone, but it's just an example of the fact that if one does not change or challenge themselves to improve, then you stagnate and you stay in the same old modalities in the same place, as opposed to process improvement allows you to grow as an individual and expand your horizons. Okay. I think that's it. Yep. And so we do have some questions that have shown up. And so guys, I'm gonna kind of enlist you to help me with answering some of these.
Just real quick, I was just going to say the biggest selling point, I think, on this technology is not necessarily the immediate results you get, because you get immediate results and everything looks good on the angio with a lot of different devices. But I think as you look at the 6 months down the road, 12 months down the road, and the long-term results that you're getting by, especially with the Panthera system, debulking these plaques, you're actually removing something from the vessel rather than trying to push it to the side. You're not creating the intimal damage and the subintimal damage and getting an inflammatory response and building up intimal hyperplasia afterwards. That's the biggest result that you're getting here, is down the road. Are we coming back in 3 months and 6 months to treat these same lesions again? Right. And you can really focus your therapy. I think that's the biggest thing, is that you're not treating the entire SFA. You're treating certain areas. With atherectomy, you can see exactly where, if you need to place a stent, you can place a stent in certain areas. If you get a dissection with the Panthera system, you can actually direct it towards the dissection flap and actually remove that flap, and you may not need anything there when all is said and done. Whereas previously, you may have placed a stent in that area and then down the road have to worry about, ISR, things like that.
Yes, I agree 100%. And I'll tell you, to that, what you brought up is a very valid point too, that before the advent of the image-guided technologies, I used to be a big Silverhawk user. And what I didn't realize that I was part of the problem, because with using non-image guided technology, I can't be specific, I can't avoid injury, and I can't limit the amount of what is treated, as was previously shown. With the use of the balloon on the 7 French device, you can vary the depth of your cut, and you know that you can go up to the media but not violate the media. When cutting with, I'm not trying to knock Silverhawk or Diamondback, and everybody's going to use what they use, but it's very indiscriminate in its application, and there is no specificity to it. It's just going to treat wherever you put it. So one of the questions is, how do OCT guided technologies for crossing and treating compare to other technologies that you have used for this lesion set? And I will tell you, from my standpoint, I view the Pantheris and the small vessel device not as atherectomy devices. I view them as imaging devices that allow you to treat atherosclerotic disease. And I know that may be, a little bit of mincing words, but I think there's a vast difference, because there's no other technology that is currently available that can achieve the results and the safety profile that the Avinger products achieve. And if you guys have any other thoughts on that.
I
Yeah,
agree
I
with
agree.
you, Glenn. I'm sorry, Mike, go ahead.
No, go ahead, go.
I was going to say that I completely agree with you. I mean, the way I would describe this, and this is just an analogy, when I started out as a baby doc, it was all about, when we get access in the femoral, you would feel it, and you'd spend an hour, and you'd, be real precise with it. And it was just like a part of like being a good interventionalist, is being able to get access in anything. But now we've evolved. Now everyone gets ultrasound guided. I think everybody does, right? Ultrasound guided access to common femoral, to veins, to tibials. It's no longer, I feel it. So my point is that there's an evolution, because we want to do things better. We want to do things more safely. We want to be able to do things more accurately. And so the ideas of crossing occluded vessels with, I can do this. With my wire, and I know it's true into mine. I mean, I'm not saying people are not able to do that, but why not be able to do these same techniques, and you're within the lumen, that you're cutting in the right place. And I think that's the evolution that exists. And I think sometimes it's just one of those things that we just have to kind of realize that, like, from a safety standpoint, from an efficacy standpoint, doing things with imaging is important. Is the next step.
And then after you get comfortable with it, you think back and you say, well, how was I doing that before? How was I cutting blindly? Then you wait till you get the catheter out, exchange, then do a picture, and then react. This is not a reactive treatment anymore. It's being very proactive about what you're cutting, what you're doing, seeing it exactly in real time. There is no exchange to take the treatment catheter out, to put an IVUS catheter in, to take that out, to put another treatment catheter in. So the efficiency of your case increases significantly, because you're doing multiple steps at the same time, and being very precise about where you're actually cutting.
Where you're at. Yep.
And I'll tell you that, just thinking when you're talking about the evolution of things, and I agree 100%, in imaging, would Mike, would you consider ever doing a TVAR for a dissection without IVUSing to make sure you're in the true lumen?
I think nowadays, and at least my practice, I'm not relying just on angiography alone. We're doing separate imaging. You need another modality to find out exactly what that lesion looks like, and get the real
and the extent of
material characteristics of it, and make sure you're in the lumen, make sure you're exactly where you think you are. We just had a case the other day, in an unrelated fashion. This was a venous case, but there was a venous anomaly, and there was 2 parallel vessels. And on fluoroscopy, you look like you're in the one lumen, and it didn't make any sense. We put an IVUS catheter up, and we saw 2 parallel. It's basically a duplicated iliac system. On the fluoroscopy, it looked like just one system. And so without extra imaging, we could have done the wrong thing there.
All right, another question is, what are the most important clinical best practices to keep in mind when crossing and treating CTOs with OCT guided technology?
Be patient. It's, where you, especially ocelot, like, sometimes these lesions take a little bit to cross. It's not necessarily going to be a 1 minute cross across the lesion. Like I've had lesions where we're sitting there kind of drilling for like 15, 20 minutes. You're making progress, you're staying in the right lumen. And as long as you're making progress and you're not forcing it, I think you'll end up with a good result. When you start to get impatient and put a little more pressure on the catheter and push it a little more, now you start to lose the imaging, because if there's too much pressure, the imaging gets a little blurry, and now all of a sudden you lose your planes, and then you get into the situation where you're pulling back. So I think it's very important to what these cases are. You're not going to fly through it. You give yourself enough time for the case, and you're just patient with the treatment. And once you get through with the ocelot, I think you can take a big deep breath, because now, like you said earlier, there's a 2 millimeter channel. You can get a wire catheter down there. You can get your spider wire down, and now do whatever other treatment you need to do at that point.
So I think go ahead. I'm sorry. Go ahead.
I was going to say, for me, I was going to say a commitment. Like for me, I committed to treat or to deal with every CTO that I had initially with the ocelot system, just to be able to learn how to get through. So you have to learn how to get through. That's the main thing. And the second thing is realize that my opinion is that if you're trying to treat OCT, if you're trying to cross with OCT guided systems, if you cross 75%, 85% of the way, and you're not able to get through the whole thing, it's not a non-success. I mean, if you're able to spend, if you need to do some fancy stuff to get the last 10, 15 millimeters through, that's not a non-success, because again, I'm still a huge proponent of exactly what the data that Mike presented, that if you have a true lumen cross, the more you have true lumen cross of a vessel, the more robust your outcomes are, the more durable your outcomes are. And for, especially for claudicants, that's huge. For wounds, it's a different issue, but for claudicants, that's huge. So that's what I would say. Like, people like, oh, I didn't get across. So this is a bust. It's a freaking 300 millimeter SFA that's, half made out of stone. It didn't get across. No, that's not it. If you got through 75% of it, that's pretty freaking good, in my opinion.
All right, last question. Why did you choose to adopt OCT guided technologies into your treatment algorithm for CTO crossing and treating? I think we've kind of gone around the periphery of this, of why, but for safety reasons and for improved outcome and the best practice for the patient, unless you guys think of other reasons or other sort of caveats regarding that.
I can tell you why I chose it. My good friend, who was my partner, who was a vascular surgeon, he passed away from head and neck cancer, and he had never smoked. He had never had anything. He just lived under the fluoro, and it freaked out pretty much every doc that worked in that lab. And that's what initially introduced us to the OCT guided system, because you're able to cut back your fluoro time to like 10%. I'm able to do cases with 0 dye. I'm able to do multi-level CTOs with just a little bit of CO2, and that's it. And it allows you to treat multiple levels. I think there are a lot of cases that can't be done effectively, especially if a guy's got a kidney function of 3.5, creatinine of 3.5. You can't give him dye, but you can do it with this kind of system. That's my thing.
Yeah, good, very good points. Very good points.
I agree. And it's a safety issue for the staff, like you said, and the operator, the surrounding staff. It's a safety issue for the patient, because they're absorbing all that radiation as well. Yeah. And if they need to come back in 6 months, in 12 months, that's a whole nother case, a whole nother risk to the patient with anesthetics and another round of radiation for the patient. So these things are all additive. And we all know we've had these patients that come back every 6 months with these lesions over and over and over again. So for me, my goal is, what is the procedure I'm going to do for them that's going to give them the best long-term outcome? Even if it takes longer at that first procedure, I think it's worth it to avoid all the secondary and tertiary procedures that are likely to come from other technologies. And for me, I think debulking these lesions is the most important. You can squish all the plaque against the wall you want. It's going to ultimately crush that stent if you didn't remove anything. And so I try to remove as much of this plaque as possible with the atherectomy, and then do selective stenting if necessary.
All right. Any other last thoughts that you guys would like to share?
try
I
it.
mean,
You'll like it. It's good.
Yeah, I mean, that what I would say is that anything new is a little bit imposing, and it's okay to feel uncomfortable. What's not okay is to not do something beneficial for the patient because you feel uncomfortable.
Right.
It's about improving yourself. So
Right.
thank you guys very much
Thank
for
you, guys.
participating in this and sharing. I appreciate it.
Thank you.
And I think we'll
Yeah.
see each other later.
Absolutely.
Alrighty.
Thanks for the opportunity.
Thank you,
Have a
guys.
good night.
I just want
Have
to
a
thank
good one.
who logged in and joined us today. I'd also like to thank Dr. Schwartzberg, Dr. Lieb, Dr. Koul, for just sharing your perspectives and thoughts on crossing and treating CTOs. So now the CTO webinar has now been concluded.